Nirup, Professor Manoj sir is joining, Dr. Nirup. You are in
Yes,
mute
sir.
mode, ma.
Yes, sir. Yes, sir. Yes, sir. Yes.
Should
I'll
I
just
call
him
or
up
you
again.
call, ma?
I'll call on once again, sir. I'll just call.
Yeah. If he comes, then if he's going to take time, it's 8 o'clock. We can start the thing. Please kindly check with Professor.
Yes, sir. Yes.
Dr. Taruni, good evening. Try sharing your PowerPoint, ma. Professor UP, sir, are you with us?
Sir would be joining in 5-10 minutes, sir.
Okay. Should we wait? Can we start by the time you start your presentation? Other faculties have joined already.
Yes, sir. Sir said to continue, sir. Yes.
Okay. So, good evening, friends. We have very senior faculty today. Other faculties are just in the process of joining. We have Professor Som Prakash Basu, sir, Professor Rajesh Sakai, sir, Professor Srinivasan, sir, already with us. And other professors are also expected to join shortly, because two of them have called up to tell that they're just finishing the case and they'll be joining us.
We have senior faculty today. Other faculties are just in the process of joining. We have Professor Som Prakash Basu, sir, Professor Rajesh Sakai, sir, Professor Srinivasan, sir, already with us. And other.
So we have two important presentations today. One is
Dr. Dharuni is logged in with two devices.
Yes. Dharuni is not use one device.
Saying some audio challenge is there today.
No, she's logged in with two devices.
One device.
Okay, I request all of you to mute except the faculty and the presenters, please.
Taylor, sir.
So those who faculty and presenters alone, unmute yourself. Nirup, you can start sharing your PowerPoint. Introduce your unit chief, your head of the department, and start your presentation. Okay. Faculty, please take over. Share your screen, Nirup. Jalal sir, good evening, sir.
Hello, sir. Is it visible?
Good evening.
You are good to go, ma. Make it full screen, ma.
Yes, sir. Good evening to all the respected faculty. Myself, Dr. Nirup BS, third year, final year resident from Department of General Surgery, IIMS Patna. I'm presenting a case today under the guidance of my head, Dr. Manoj Kumar sir, Professor and Head of Department of General Surgery, IIMS Patna. Going on to the case, here's my patient, 56-year-old lady, married, homemaker by occupation. She hailing from Godda, Jharkhand. She presents to us with yellowish discoloration of eyes the past 2 months and generalized itching for 1.5 months. History of presenting illness, yellowish discoloration of eyes and urine for 2 months, which was initially first noticed by the family members, which is insidious in onset, gradually progressive, now involving palms and soles, which is associated with the passage of 2 to 3 episodes of black foul-smelling tarry stools in the past 2 months, and it is not associated with pain, abdomen, or fever. There is no waxing or waning or any kind of fluctuation of jaundice in the past 2 months. There is also a history of generalized itching all over the body for 1 month, which is insidious onset, gradually progressive, which also aggravates in the night and is not relieved on any medication. There's a history of passage of pale-colored stools. There's a history of significant loss of appetite and weight. Although it is not quantified, patient gives history of loosening of clothes. There is no history of nausea, vomiting, or pain abdomen. There's no history of fever, chills, or malaise. There's no history of mass abdomen or abdominal distension, no history of altered sleep pattern or mental status or bleeding tendencies. There's no history of any endoscopic interventions in these 2 months. Past history, she is not a known case of any comorbidities. There's a history of tubal ligation 25 years back. There's a history of laparoscopic cholecystectomy 5 years back in a private hospital, during which a drain was put in and it was removed on post-op day 1. The post-op course was uneventful and she was discharged on post-op day 2. There's no known allergies. She is not on any long-term medications or any drug intake. There's no history of any blood transfusions in the past. Personal history, she consumes mixed diet. Appetite is decreased in these 2 months. Sleep is disturbed mainly because of itching. Bladder and bowel habits are regular. There's no, she denies any kind of addictions. Menstrual history, she has attained natural menopause 15 years back. Obstetric history, she has 2 children, P2, L2, E0, all normal vaginal delivery. Family history, there's no history of malignancy in the family. Summarizing my history, here's a 56-year-old lady, homemaker with known comorbidities, with a history of laparoscopic cholecystectomy 5 years back, has presented to us with history suggestive of painless progressive jaundice. It is associated with generalized itching, melena, and passage of pale-colored stools, along with history of unintentional significant weight loss.
Okay, Nirup. So what do you think your diagnosis is by your history?
So this is of this is jaundice of very short duration, and jaundice I am thinking it is of obstructive jaundice. So of its short duration obstructive jaundice, I am thinking of an obstructive jaundice of malignant etiologies.
You should just say surgical obstructive jaundice, SOJ. That's it.
Yes.
Malignant, you can't say malignant just now.
Yes.
Right. Short duration can be because of stones, also because of anything, because of external lymph. That's
Yes.
your first line.
Yes.
What made you to think is an obstructive jaundice?
Sir, she is complaining of, sir, yellowish discoloration of eyes and urine, and she's
total duration.
Sir, 2 months. Sir, 2 months.
Okay.
And she is having history of passage of pale colored stools. And so to rule out medical jaundice, there is no history of any prodromal symptoms like fever, malaise, or myalgia, or arthralgia. So I might rule out that. And presence of this eye colored urine also rules out the pre-hepatic jaundice also as well. So I'm thinking in terms of obstructive jaundice.
Because
you said
jaundice can be.
Yes.
Sorry.
Sir.
In progressive jaundice, you can get in hepatitis B also.
Yes, sir.
And
yeah. But sir, she would have had other prodrome symptoms like fever or some myalgia or arthralgia before that. Sir.
No, it is a 2 months history, no?
Yes, sir.
No, by the time patient would have been forgotten that. But what made you to, with a short duration, 2 months, straight away you are going for the, how much time it takes for a deepening of the jaundice to visible? What is the half-life of the bilirubin?
No, sir, I'm sorry, sir.
Okay, it is 2 to 3 weeks, 21 days up to it can be there. Okay?
Yes,
because it's always bind with albumin. So it takes a long time.
Bound to albumin, yes, sir. Yes.
So why do you see the jaundice only in the conjunctiva more?
Sir, the sclera contains elastic fibers and it has got special affinity towards the.
No, hang on, Nirup.
Yes,
the yellowish, this thing is of the sclera or of the conjunctiva?
Sclera.
No, it is of the conjunctiva. You
Superior
see it
passage.
against the white sclera.
Yes. Yes. I'm sorry, yes, sir. Yes.
Okay. So what is that white? How it helps? Is that the elastin is there? Not only there, elastin is there in many other parts of the body.
So that is where we could easily appreciate it, sir, against its the white background of sclera, yes.
No, why it is? Because you do not have a melanin pigment is not there.
Yes.
So that is the reason why you are able to see it. Yes, elastin is more sensitive. It is coming there.
Okay.
What is this color of the jaundice? You have put only as a progressive jaundice. Is it a green or it is a brown or?
No, it's a color associated with the amount of bilirubin.
Yes, sir. Initially, it might be yellowish tinge. It gradually deepens up. It can turn to even greenish to brown also.
Yeah, because
That's
you are not mentioned it is a progressive deepening or it is just
Yes.
a progressive. It can be still an yellow. It would have been even
Yes.
a bilirubin level less than 4. It can be also 4 to 5 is also progressive.
Yes.
Same problem.
Yes, sir. As per the history, she also complains that it has been deepened and it has increased. Yes.
Oh. What is the
Yes, sir.
end stage of the deepening of the jaundice? What will be the color?
Brown, sir, brown.
What is that? It is due to?
It gets reduced back to the biliverdin.
Very good. It is due to the biliverdin, not due to the bilirubin. So bilirubin will be produced a greenish color. Here you are saying the biliverdin. And if there is an itching which is only in the night, is it significant? You said the itching is not making her to sleep.
Yes, sir. It is disturbing the sleep.
No, what is the reason? Why it is not there? You say that then daytime there is no itching?
Sir, it could be there in itching, but the other sensations would mask that effect of that itching sensation, which is more easily observed in the night, where she's not doing her activities or she's not, maybe because of that.
Why there is itching?
That is because of the deposition of bile salts in the skin. Sorry, sir.
What are the bile salts?
Azodeoxycholate and not remembering.
You are meaning bile acid or bile salts?
Bile salts.
So
Bile salts. Bile salts.
What are the bile salts?
Sodium deoxycholate and
No, these are some basic things you must just don't go what is primary bile salts, what is secondary bile salts, and how the bile salts are formed, and why the bile salts are producing itching.
So they are irritating the free nerve endings in the skin. That is one proposed mechanism. Other is that they release histamine from the mast cells, but there is no proven theory. What is the exact etiology behind it?
Okay.
Okay, Neeru, what are the other diseases in which can get generalized itching?
So skin diseases, fungal infections.
Because so fungal will not be generalized unless it's widespread. Yes. I'm talking of this kind of itching, which is similar to your obstructive jaundice.
So psoriasis.
Psoriasis is not an itchy. It's not an itchy.
It will not produce itching much.
It's not itchy.
It's a 56-year-old.
You see, you know about it. You present the case every time.
Any systemic disease?
Systemic disease. Lymphomas?
Yes.
Right. What else? Multiple myelomas?
Yes.
So these are the ones which are common ones. There are others also, but these are common. Even anemia can produce itching.
Okay.
Right. You are repeatedly asking the laparoscopy cholecystectomy. What is the significance?
I mean, why did you ask for day one? Drain removal at day one. How is it significant here?
No, sir. I was just sir, I was just eliciting the detailed history of that event.
Come on, she might have told you anything. She might have told you she'd worn a green sari on that day. So you'll put it in the history. You can't do that.
Yes.
It's got no significance unless of course, she had a problem post-operatively.
But what we are interested is what was the biopsy report of that laparoscopic cholecystectomy?
Yes. Sir, I was thinking in terms of any bile duct injury.
That will not happen after 5 years, no?
5 years.
Yes, sir. That is what, sir. Yes. But I just took the history, but it is not correlating with that.
No, sir. Asked you about biopsy.
Biopsy. There is a what is the significance of gallbladder malignancy? What is T1 lesion in gallbladder malignancy?
The T1 is just involving the mucosa, sir.
What is the histological difference between GB and the stomach?
There is no lamina propria in that series. In the
only lamina propria.
So there is a difference in the staging of the stomach and GB.
No, I am not asking the staging. It is only the mucosa is there. Then straight away you are going for the
muzzle.
So lamina propria and submucosa is not there.
Yes. Yes.
So if there is a early lesion, you would have been there. If even the histology would have been given, if that could have been recent, would have been an early T1 lesion. So after a long time, it is some metastasis happening. That is also very remote. But
Yes.
here, not the first day removal of the drain.
Yes.
Or then, but more important is what we are is a biopsy. You could have, but you are not mentioned. You could have mentioned that patient is not aware of the biopsy report.
Yes.
That will give you the broad outlook that you are looked into that.
Yes.
Okay, could you go back to your first slide, please? Next. Okay. Okay, for generalized itching. Okay, we'll talk about it later when we come to the management. Next slide, please. Not relief on medication. What medications do you give to relieve generalized itching?
So she, before coming to us, she was on medications which she is not aware what actually she is on.
No,
but
okay. Suppose that she's come to you.
Yes, sir.
Had she come to you before, what
Yes,
medication would you have given to relieve her itching? What would you have
sir,
done? Rather, what would you have done to relieve her itching?
So I would have advised her some emollients like coconut oil.
Okay, that's fine. What else?
Yes, sir. And I would ask her to maintain her hydration, avoid
what else?
Exposure to the sun or avoid dry.
Anything specific? Anything specific?
Sir, antihistamines and anti-opioids, we can give it to them, but
anti-opioids.
Naloxone.
Okay.
Yes.
Anything before that?
So we can give cholestyramine.
Cholestyramine is first.
Yes.
Is the first line of. Then second line of drug.
So cholestyramine is the one which we usually.
No. The other drugs. Come on. Don't. You don't tell that there are no other drugs. You say you don't know.
Yes.
You can't say there are no other drugs. Ursodeoxycholic acid.
Yes, sir.
UDC.
Then
rifampicin. Even rifampicin.
Yes.
Right.
So your fifth line, ASS with the passage of black tarry stool.
Sir,
what do you mean by ASS?
Sir,
as everywhere.
Sorry, sir. That was associated with passage of. Sorry.
No, you can't make this mistake. No,
don't do.
Yes, sir.
And the later part you have said no melina, but here you are writing black tarry stool is there.
No, sir. I have mentioned it melina, sir. In the summary slide also. Yes.
So this patient had a melina, but
yes,
no
sir. Sorry, sir.
You said there is a melina,
yes,
black tarry stool, but no waxing or veining. So what you suspect the bleeding is due to?
So she is not able to appreciate that waxing or veining type.
And within 2 months, 2 months, can you appreciate the waxing and veining?
So it could be, sir, depending upon the tumor biology. If it is
definitely not. Once it is there, it takes long time for the regrowth, the periampullary growth. If you are suspecting it to grow to come, you will never get waxing and veining. And waxing and veining is even in the full-blown periampullary carcinoma, it is only less than 20% people will have. So don't make it as a big thing again and putting no waxing and veining for part of it.
Okay.
Okay, Niru. Suppose. What is the cause of waxing and veining of this jaundice?
Sir,
and then how do you ask for it? How do you take
yes, sir. As the tumor grows in size,
what size is generally? Yeah, go on. Please go on.
Yes,
sorry.
Yes, as the tumor size grows, so the center part of the tumor will be lacking the blood supply because of deficient blood supply. It goes into necrosis. So that partially.
What tumor?
So mainly specifically this is ampullary part of the periampullary group.
So not it is all periampullary, only
ampullary portion.
Ampullary part of the periampullary.
And if it grows more than 4 centimeters.
More than 2.53 years. Okay.
Yeah, right. So there's waxing. So how do you take the history for it?
Waxing and veining of what?
Jaundice, sir.
Jaundice.
So don't try just waxing and veining, right?
Yes, sir.
Of jaundice. How did you ask for history of waxing and veining?
Sir, very few patients should be able to appreciate it, but
no. How did you ask for take the history? You said no waxing and veining. So what do you ask the patient?
So one thing,
you are still in the clinical examination.
Yes.
Then you don't have the bilirubin level estimation. You can't do.
Yes.
And you can't say that the jaundice is high or low just by looking at that. And for to ask getting the vaccine waning, what you ask? What is the history you will ask patient?
So one, she might feel better with respect to the itching, or she might have that good appetite, or so related.
Right. Okay, that's
It's
fine.
not a jaundice. It is a symptomatic improvement. Patient
Yes.
has symptomatic betterment. Is the most important.
Okay, so Nirup, your patient has no waxing and waning of jaundice,
Yes, sir.
yet has melena.
Yes,
How will
sir.
you explain?
So how do you explain this now? What malignancy will you think of now? Okay, tell me what are the periampullary carcinomas? You just name them out.
Sir, ampullary variety, duodenal, distal cholangiocarcinoma, and head of pancreas, which is arising within 2 centimeters of the ampulla of artery. Yes.
So out of these four, which one? The gallbladder is out.
Yes,
right?
Sir. Yes.
Now, out of these four, which one can explain these two? No waxing and waning with melena.
It is in you have
probably duodenal adenocarcinoma.
Okay, duodenal is one because why? Because there's ulceration. Anyone else? Any other malignancy that can also give?
Distal cholangio would relieve would cause waxing and waning, but head of pancreas are the ones.
Yes, head of pancreas when it infiltrates into the duodenum.
Yes. Okay. Yes.
So you can get a hemophilia if it is there is bile ducts also. If there is a blood enter somewhere, it can also produce that. Yes. What do you mean by melena?
So melena is a passage of foul-smelling black tarry stools is termed as melena. So it signifies
not foul-smelling always. Okay. So okay, you can say. So what is from up to where you get a melena?
So proximal to the ligament of Treat.
Where is it? Ligament of Treat?
It is between the D3 and D4. Sir.
D3 and D4.
Mm-hmm.
Yes. Where is ligamentum teres? And from where to where it goes? And what is the significance of that?
Sir, it is embryologically between foregut and midgut, but attachments are I have to revise again. I have to go through it. Yes.
Okay, it's a DJ junction.
Yes,
DJ record tree also comes there.
Niru,
yes, sir.
It is not the junction between foregut and midgut. The junction between foregut and midgut is the ampulla of Vetter.
Yes.
Okay. Okay. Sir.
Yeah. So yes. Can you get a melena when the lower GI tract is bleeding?
Sir, we can get it if the transit time is lower.
What is the difference between that blood and this blood? That is also black, and the melena in the lower GI tract also you can get a black.
Yes, sir. Yes.
So what is that black is due to in the lower GI and what is in the upper GI? So it is acid hematin.
Yes, sir. It gets converted to the hematin. Yes.
Okay.
Hang on. Let's tell you.
Yes.
Yeah. What is the other form? Why is it black otherwise? One is acid hematin.
Yes, sir.
That is
I don't know the reason
onto the hemoglobin.
Oxidative reduction by the
enzymes
and bacteria.
The second is because of bacteria.
Okay, sir.
Bacteria, they do the oxidative reduction. So that can also, because it's a slow passage when it passing through the slow. Yes. So if undergraduate says melena is only from upper GI, it is accepted. But postgraduate should always have a thing. It can also also.
Yes.
Okay. Yeah, how much blood should come in the GI tract to produce one episode of melena?
I'm sorry, sir, I didn't get it.
How much blood you should have? Minimum amount of bleed is needed.
What is the volume of bleeding which will lead to melena?
Sir, I'm not sure, but I would take 20 to 30 ml. Sir.
But no, it is about 60 ml of blood minimum, yes, and it should be there for 2 to 3 days.
Yes, yes.
And how much time it takes to recover? How much time it takes to recover? How long it will be? You can have a melena. Okay. It's also a long period.
Okay, Niru. Now, suppose this patient was bleeding, but there's no melena. So what would we call that?
So bleeding, sir, from
You are not sure there is a bleeding, but you are not getting a
melena. What do we call that?
occult GI bleed, sir.
Right, that's so called occult blood. So there can be occult blood in these kind of patients,
Yes.
even if there is no melena. Melena is seen in very few patients, right? Okay, next slide, please.
You are again and again saying aggravates in the night, but the itching which aggravates in the night is more of a scabies.
Yes.
So remember whether you are sure whether the history you are taking or just taking it granted. You must then ask the patient detail, or then you must also ask whether there is a dissociation, whether he has a night will become daytime for them in a hepatic failure. So,
Okay.
certain
Most
things you are not
of these
sure,
patients,
don't make it again and again.
Yes, sir.
yeah, Niru, most of these patients actually can't sleep at night because of the itching. That perception happens because of the cortical inhibition decreases. In the daytime, they get more involved with daily activities,
Yes.
distracted here and there. So that feeling is more. They usually complain, but actually they have it throughout the day, isn't it?
Yes, sir.
Okay. Why did you ask for history of fever, chills, and malaise?
So one, sir, one is to rule out the medical jaundice, cause of medical jaundice, and other is like whether she had any episodes of cholangitis because of this progressive jaundice.
Why do you expect cholangitis and obstructive jaundice?
Sir, one, if it is because of stones, stone acts as a foci for infection one. Another is there could be an ascending tract of ascending cholangitis from the duodenum. Yes.
You mean to say the bacteria in the duodenum climbs up through the CBD?
So that is one of the mechanism of pathology for the cholangitis.
No. That's not the mechanism currently not believed at present. For that, the duodenum has to harbor very pathogenic organisms.
Yes.
But
Then
duodenum
even
doesn't
without
do
obstruction,
that.
it can produce that. If there is pathology organism there, even without obstruction, it can produce cholangitis.
Yes. So you have to have a stasis there, number one.
Yes.
And there is something which is known as endogenous mucosa associated organisms that happens in every hollow organ or hollow part of the GI tract, right?
Yes.
Yeah, and they interact with the cholangiocytes and they produce that severe inflammation.
Okay, let's go to the next slide, please. Tubolation lab. Okay. Next slide. What do you mean by menopause? How do you define menopause?
So cessation of menstruation for at least more than 6 months.
6 months. So every pregnancy is a menopause. So every pregnancy is a menopause. More than 6 months.
No, sir.
What is the definition? There is a standard definition for menopause.
So cessation of menstruation for at least more than, sir?
Or how long?
So 1 year, more than 1 year, with without any
therapeutic or
yes.
You have put that word somewhere. You have put physiological. Okay. So
okay,
your patient has melena. Your patient has loss of appetite. All that doesn't fit into your problem with is it an GI tract pathology? Sudden within 2 months he is losing weight. Loss of appetite is also there.
Yes, sir.
Melena is very significant.
So it could be duodenal adenocarcinoma, GI.
No, you come to that when you come to the clinical examination. May be there with some findings. Okay.
Okay, next slide, please. Family history. What family history did you ask for?
So one, was there any jaundice in the family? And any kind of... Sorry, sir?
No, any jaundice in the family is not a family history for malignancy.
Not for the malignancies, sir. Not for the malignancies.
You said no history of malignancies in family.
Yes, and for the history of malignancies, like any GI malignancies, or breast or ovarian malignancies, which are related to the genetic associations.
So they will produce obstructive jaundice.
Pancreatic malignancies, which causes obstructive jaundice.
Okay.
Yes.
Okay. Next slide, please. Okay. Should we move to the examination,
Yes,
sir?
yes.
Yeah, please,
Okay.
examination.
Patient was examined in broad daylight after due consent in the presence of female chaperone. Patient was conscious, cooperative, and well-oriented, time, place, and person. Patient is she is averagely built and moderately nourished, with height of 145 centimeter, weight of 40 kg, amounting to BMI of 19.01. The COG performance status is 1. Coming on to vitals, pulse rate is 62 beats per minute, regular in rhythm, normal character, and good volume, with no radial delay or radiofemoral delay. Blood pressure of 126 by 78 mmHg, measured in right arm in supine position. Respiratory rate of 16 cycles per minute regular, and she is afebrile to touch. Pictures noted in the deep pictures noted in the sclera on the floor of the mouth, palms and soles.
How do you look for jaundice?
Sir, we ask the patient to look down and we retract the upper eyelid, sir.
Where do you stand?
We see the just above the superior limbus.
Where do you stand?
Superior palpebral conjunctiva.
Where do you stand while you are examining that?
So I would be standing directly in front of the patient.
You should never stand in front of that. Why you?
Yeah. Why should you not stand in front?
So we might obstruct the light.
Yeah.
You are going to examine the daylight.
Yes, yes.
No, these are small things in the examination. We will ask you to check for jaundice. You will immediately go and stand in front of that. So this procedure, clinical procedure and examination is more important than your all the theoretical knowledge.
Yeah.
Okay. Even examining how you are going to examine palm, where you are going to examine. Are you going to examine anemia separately and jaundice separately or simultaneously?
Sir, simultaneously, sir. But if it is a deep interest, you might not be able to appreciate it. Yes.
You have only very limited time. Then you must do all the test. Okay, go ahead.
There's no cyanosis, clubbing, lymphadenopathy, or edema. Scratch marks were noted over the abdomen and extremities. No signs of liver cell failure were noted other than a jaundice. There's no signs of dehydration.
So you look for liver cell failure.
Sir, since the patient is presenting to us with jaundice, I also look for the other signs of the.
Are you going to for the decompensated liver or the liver disease pattern, or you are going to see the liver cell failure? What are the signs and symptoms you look for failure?
Ascites, sir. Ascites, caput medusae, alopecia.
Hypertension.
I'm sorry, sir. Yes, sir. They are also part of
these. These are features of portal hypertension you're talking of.
Yes, sir. They are also part of
the features.
Sir, alopecia.
That is not a feature of liver cell failure. No, you say hepatic failure, renal failure. There are criteria to call something as a failed. Something is decompensated or compensated. Chronic liver disease is a different thing.
Yes.
There you can get all these things. Once the patient is failed, the liver is totally failing, you will have only certain signs. If asterixis or the flapping tremor, you will have the consciousness part. Okay. So don't mix both. Patient can have alopecia, gynecomastia, all that's a routine liver cell failure. Even the patient with the cirrhosis can have that, but doesn't mean that his liver is failed.
Okay, yes. They are the signs of chronic liver disease. Yes.
So they are both are separate. Chronic liver disease, you say. So you are going to only see that because you are not going to deal with the case of liver cell failure case here.
Okay.
So you can check for the, and for that each reason you must know. How do you get? Would you get gynecomastia in a liver cell failure? It comes in liver disease.
Sir, it is because of the peripheral conversion of the testosterone to the estrogen, where because of the imbalance, then you get gynecomastia.
There is imbalance between the testosterone and estrogen because of the binding globulin is increased. So that will be okay. That's all mechanism. That's a theoretical. You must know. Go ahead.
Patient was examined in supine position with slight flexion at knee and hip joint, with thumbs by the side and with adequate exposure. On inspection, the abdomen appeared flat, umbilicus is in center and is inverted. All quadrants move correspondingly with respiration. Yellowish tinge of the skin was noted. Scratch marks were appreciated. 4 scar marks of the pores at usual sites of laparoscopic cholecystectomy were noted. A vertical scar mark of 5 cm in the midline and the suprapubic region was noted. There's no visible fullness or lump noted. There's no venous prominences, sinuses, or visible pulsations or visible peristalsis. The anal orifices appears
What
intact.
sinuses you looked for?
Sir, any post-operative sinuses since you're already on.
Already you have mentioned about the scar, no? There is a scar you have mentioned.
There's an healed scar. There is no any sinuses present.
Okay, but what is the sinus you are looking for?
Specifically, sir, obstructive jaundice, sir.
No, in this case, you see, something which we think of, we are going to look for it.
Yes, sir.
If you have anything in the mind, you are going to look for that, and it has significance. And what that you are looked for in the sinuses? Don't make it as a routine statement. Just for that, you are going to dip for the completion's sake.
Yes, Nirup, you're going to be a surgeon. It's not MBBS exam.
Yes.
So you must say things which are going to look for things which are going to affect your diagnosis or help in your diagnosis. Just randomly rattling off, no sinuses, I will say no white patches, no discoloration, all that kind of, it's just meaningless.
As far as trying to avoid that, okay?
Okay. Yes. On palpation, there is no.
Niru, go back to the previous slide.
Yes, sir.
Yeah, you mentioned external genitalia appears normal. This is a lady. Why did you actually look for it?
You don't.
Yes, sir, it was. I was just
Really
looking as a part of the examination. Yes.
So that is what is being pointed out at every
Yes.
point.
Yes, sir. Yes.
That you are now a postgraduate going to be a consultant. So your approach to a patient should be patient specific and very focused.
Okay. Sir. Yes.
When you don't maintain this, these things happen.
Yes. On palpation, there is no local rise of temperature, no tenderness. Liver was palpable in the right epicondyle, 2 cm below the right costal margin in the midclavicular line. It is non-tender, smooth surfaced, and firm in consistency with rounded margins. On percussion,
I have a question here. Please go back to the previous slide. Okay. So you said 2 cm below the right costal margin is palpable.
Yes,
So which phase of respiration do you actually do that?
So what we do is, so we press in the hand at the time of expiration, and it is just felt. The liver just is felt at the peak of inspiration, sir. And we as the patient inspires, we take out the hands. So it is being at that phase. The liver is palpable at that.
Okay. Carry on.
On percussion, the upper border of the liver dullness was felt at 5th intercostal space in the right midclavicular line, up 2 cm below the right costal margin. The liver span was 13 centimeters. There's no evidence of free fluid noted. On auscultation, bowel sounds were heard and were normal.
The liver is enlarged or not?
No, sir. 13 centimeters.
You said you have felt liver 2 centimeters below.
Yes, sir.
So, and the upper limit was only at the 5th intercostal space.
Yes, sir.
So now mean to say that liver is normal, not enlarged.
It is 11 to 14 centimeters a normal range, so I would not consider it.
Where it will be 11, where it will be 14? If you are going to percuss straight on the midclavicular line, it will be only 11.
Yes, sir.
Okay. So when you are going then up to the mid-axillary line, it will be become a 14.
Oh, yes.
So where you have done that, and 13 is something which, because already you have said it is 2 centimeters below the costal margin, you are able to palpate.
Yes, sir. So,
and
but
is only 5th. So there is.
So, but one up to, sir, 1 finger below the costal margin is said to be normal.
So you are saying this is the normal liver?
Yes, sir.
Oh. What is girdle saying?
No, sir. No, sir.
Visceroptosis?
So,
oh, it's only liver, normal liver can come down.
Okay. On per rectal examination, no pelvic deposits felt. Finger was stained with pale colored stools. No supraclavicular lymphadenopathy. On systemic examination, respiratory system bilateral equal air entry noted. No added sounds. Cardiovascular system S1 S2 ERT, no murmurs. Central nervous system, no focal neurological deficits noted.
Niru,
Yes, sir.
what do you actually mean by pale colored stool? Now you have seen the stool.
Sir, I have seen the stool, sir. Yes.
Yeah. So what do you mean by that? What color are you actually pointing out? There is no color. Actually, you have mentioned pale colored. So it can be pale yellow, pale green, pale red, pale blue. You have not mentioned the color here.
Sir, it is. I can say it is pale yellow to pale green. Sir, it was not as normal. Sir.
Pale yellow to pale green in obstructive jaundice.
Pale green.
Pale green.
It was like.
That
what type of stool
pale yellow, pale green also.
I'm sorry, sir. Yes.
What type of stool do you expect in obstructive jaundice?
So it would be a clay colored stool, sir.
What is clay colored stool?
So, since the bile is not coming into the
no.
What is the color of clay? Sorry, sir.
How do you know the color of clay?
Have you seen a clay?
Yes, sir.
What is the color?
Grayish.
So clay. What is clay actually?
It's something that is moldable. That is.
Clay is mitti.
Yes, sir. That is yes.
So color is like soil, isn't it?
Okay. Yes.
So it doesn't have any color. The stool doesn't have any color except the soil colored. Don't think the clay is China clay white color. It's not white.
Okay.
It is when you take the color away from the stool, that color remains as like soil. Okay, clay colored. So as if the patient is passing stool which is pale soil colored stool. Okay, if you have seen it, you'll never forget it. So I have every doubt whether you actually seen it.
Yes, sir. Yes.
Yeah, go on.
No supraclavicular lymphadenopathy. Right side, left side, anywhere. It is significant for you.
I'm sorry, sir. It is a left supraclavicular lymphadenopathy. What I mean to mention was that. Yes.
Which are these lymph nodes which actually you are interested in? All supraclavicular lymph node, all those which are present in the left side?
No, so specifically in between the two heads of the sternocleidomastoid.
Yeah, why are you interested in that group?
That group of lymph nodes, they lie at the junction of the left subclavian vein and the.
Yeah, that's okay. But why are you interested in that group?
So that is because that is where the drainage of the thoracic duct occurs. So any malignancies, metastasis that can retrogradely spread.
Thoracic duct doesn't drain there. Where does the thoracic duct drain?
At the junction of the brachiocephalic veins and the jugular vein.
So where does it drain?
And the internal jugular veins. At the junction of that interjugular and the left brachiocephalic.
Perfectly all right. So why are you interested in these group of lymph nodes?
So there could be a retrograde spread from the thoracic duct if there is a blockage in that drainage in that area because of the metastatic blockage.
It's actually a embolic manifestation, isn't it?
Yes.
Okay. There is a retrograde spread because of sudden increase in intrathoracic pressure, like coughing, sneezing. So when the thoracic duct is full with the malignancy, that means especially certain types of malignancy, not all abdominal malignancies, which can precipitate into the just at the junction where it is draining. These lymph nodes are also draining in the thoracic duct at that region. Yes. So when you say that left supraclavicular lymph node, these are actually the medial group, the scalene group of lymph nodes in between two heads of the sternomastoid.
Yes.
So it is not that retrograde. Retrograde means it has to come through the thoracic duct. It is the embolic. There is the obstruction that produces other drugs, small drugs, which is there. Can you trace the thoracic duct?
I didn't get the question.
No, from you said you are the something suspecting in the liver or that region, no? And how do you expect that from there the malignancy goes to the thoracic region or the supraclavicular node? What is the pathway? In what pathway that it goes?
Sir, peripancreatic, retropancreatic lymph nodes Then para-aortic interaortocaval lymph nodes. From there to the cisterna chyli, and then to the thoracic duct.
No, that's what I'm asking. The thoracic duct you trace from the abdomen to the side. How it goes through, which opening it goes.
Okay. Yes.
At what level of the opening it goes?
Yes, sir.
What are the structures accompanying that? Okay, it is a T12 vertebra, aortic opening,
Aortic
long
opening, yes.
vein going on the medial, turning onto that left side. Right. So left side chest is drained by what?
So the left side is drained by the thoracic duct itself, so the right side is drained directly into the azygos veins. Azygos veins into the right.
Right side
superior,
directly azygos.
to the superior vena cava.
Now, is there a separate duct, thoracic duct on the right
No.
side or not? No.
No.
There is duct which drains the right upper
What is
limb
right
and the right
lymphatic
part
duct?
of it drains the right upper limb and the right to the vessels. That thoracic duct is.
I mean, lymph doesn't directly drain to the azygos vein, does it?
Through the duct, through the thoracic duct, to the right thoracic duct.
Azygos vein, what is the function of azygos vein?
No, sorry.
So it is only a connection between IVC and SVC. So it is not a conduit for the lymphatic true flow. Okay, go ahead.
Summarizing my case, 56-year-old lady, omega with known comorbidities, with history of laparoscopic cholecystectomy 5 years back, presents to us with a history of painless progressive jaundice, which is associated with generalized itching, melena, and passage of pale-colored stools, along with history of unintentional significant weight loss for the past 2 months. On examination, patient is deeply ectopic, with scratch marks appreciated all around, with normal abdomen with scar marks of previous surgeries, and with no other mass or lump palpable. Based on the history and examination, my provisional diagnosis would be it's a case of obstructive jaundice, likely a malignant etiology, probably due to periampullary carcinoma. Second differential would be a cholangiocarcinoma, and secondary is in porta with unknown primaries.
So you've taken cholangiocarcinoma differently from periampullary carcinoma?
Yes, sir. What I mean is ilar cholangiocarcinoma.
Okay.
Yes.
And secondaries in porta from with unknown primary.
Yes.
Okay. Okay. So how will you proceed?
Sorry.
Gallbladder is controlled or not yet?
No, sir. She is a post-op case of cholecystectomy. So.
Okay, sorry. Okay.
Yes.
So why are you considering periampullary carcinoma at all here?
So one, it is a painless and it is progressive jaundice, and she's also giving that history of melena also as well. So I would keep that as a first differential.
Why is it not a carcinoma stomach?
So
secondary is there in the porta.
Yes, sir.
Secondaries have gone from there in the porta, isn't it?
Yes, sir.
It can be anywhere from, I mean, any obstruction in the extrahepatic biliary tract.
Yes.
Isn't it?
Yes,
and
sir. So
any
secondary porta with unknown
primary is
primary
coming from the gastrointestinal tract.
Yes.
That would be the first thing possible. No.
Okay.
So more common periampullary or carcinoma stomach?
Stomach is more common. Stomach is.
And this patient has more symptoms of GI tract symptoms more.
Yes.
So there is no, like waxing, waning. You already said that there is history of melena.
Yes.
And the patient has jaundice.
Yes.
Right. So why you want to keep a first diagnosis as a periampullary?
Sir, she is presenting to us with the jaundice first, and that is her first symptom. So I would still think it as an pancreatic pathology than other GI malignancies. CA stomach, sir, yes, sir, I would keep it as my differential, but at the last, because she would have presented with something other than that, unless it is a.
What is the commonest presentation of carcinoma stomach?
Sir, she would have dyspepsia.
No.
Yes.
What is the
weight,
most common? Silent.
What is AAA?
Sir, asthenia, blood group, A blood group, anemia.
No, not A blood group.
Sir, anemia.
Yeah. Anorexia.
Anemia, anorexia, and asthenia.
Asthenia.
Okay.
Yeah.
So these are non-specific symptoms. Anybody can have that.
Yes.
And that's a commonest presentation. Do you need to have a gastric artery obstruction in every case of carcinoma of stomach to give rise to a suspicion?
No, sir, no.
Then, so you have got a situation where there is a suspected involvement of the gastrointestinal tract, especially the upper tract, and there is jaundice.
Yes.
And you cannot comment anything on the gallbladder because it's not there.
Yes.
So this is a tricky situation, and you are trying to think it is at the end of the bile duct. My question is, why is that? Now you have to go by the common things happening commonly.
Sir.
I mean, it may be a pancreatic carcinoma, but when you are making a diagnosis,
yes, sir,
it's a clinical judgment.
Yes,
to
sir.
deduce from the collected evidence, the data which you have.
Yes.
Your thought process is going towards melena, and then, but you can't have anything here as the gallbladder is not there.
Yes, sir.
So you have got stuck actually in the thought process, isn't it?
Sir, an ulcerated CS stomach might cause melena. That is one explanation for the melena if it is a CS stomach case. Other than that, melena can be explained by the periampullary carcinoma.
Mm-hmm.
What is the cause for anemia in CS stomach? Is it only due to bleeding? If it is bleeds, it's fine. Okay, melena can cause anemia. Any other reason for carcinoma stomach to produce anemia? And what kind of anemia it will produce? One of the A also acrohydria. Any significant on that?
Is it associated with erosive gastritis?
Yes, sir.
Yeah. So how to explain that then? Sum up to all these things.
So the absorption of the iodine, the ferrous has to be converted to ferric. That needs an acid. When there is no acid, it will not happen. So both, you can have an iron deficiency anemia, and also you can have a folate deficiency.
Okay.
So anemia can be not due to purely bleeding. Okay. So here you are trying to explain that melena need not be an ulcerative growth. So even when any type of growth can produce as the lesion. So as Sarah has said, clinically, you should have given all the clinical conditions and the history and the findings you have to explain, then putting on that. Because in this case, we can't go by the gallbladder because it is already removed.
Yes.
The patient is loss of appetite, sudden 2 months, it is a significant weight loss. She is not able to eat, and melena is there. So GI pathology is more prominent.
Yes, sir.
How will you proceed?
I have a question to the presenter.
Yes, sir.
This patient had a history of laparoscopic cholecystectomy. Sorry, I came late. The indication for surgery must be cholelithiasis.
Yes, sir.
Yeah. Why don't you think of a benign issue here, like a secondary stone in the gallbladder, a secondary stone in the CBD? Could you explain that to me? How could you? You are telling straight away. You are telling giving a diagnosis of all mitotic things here. Why not this be a benign condition?
Sir, she has underwent laparoscopic cholecystectomy, sir, 5 years back. So to say it is retained, it should be less than 2 years.
I said,
yes.
Yeah. Okay. Tell me, please.
To say, sir, it is a recurrent or a primary CBD stone, that should have been presented after 2 years. So to consider that as a primary CBD stone.
Yeah, this is 5 years.
Yes,
so
sir.
Could this not be a primary CBD stone?
So she would have had the colicky pain. She would have presented with the colicky pain, sir. That is, she is not complaining of that that colicky kind of pain, sir. And with that such deep jaundice, she would have had stone is most predisposing factor for cholangitis in case of stone-induced jaundice. So all this is not favoring towards CBD stone. Yes.
Will you not get a fever or cholangitis in a periampullary carcinoma?
We will get it. Yes, that is it is also there. Yes.
If it is so, how can you tell that this patient not having fever or cholangitis? How could you arrive at a diagnosis of periampullary here? Why not you put the second in your differential diagnosis? Why don't you add a benign condition also?
So she's having other factors like melena and as well as loss of appetite.
Melena could be a second thing for the patient. She would have had some stress gastritis or some stress ulcer due to a stressful condition like this.
So there is no colicky pains, and that is one strong factor against CBD stone.
How many percentage of patients with CBD stone have colicky pain? See, we cannot rule out a benign condition in with the background history of a gallstone disease operated like this. You can add that at the end of your list there.
Sure, sir. Yes.
Nothing wrong in that.
Yes.
There is no hard and fast rule like this. We cannot say that claim that a benign disease could not produce a 2-digit jaundice. A benign condition could not present all these things. A
Yes.
patient with jaundice will develop loss of appetite, loss of weight, and all those things. So you always add in your diagnosis. You always try to add that at least at the end of your all your diagnosis, whichever you think is important. Okay, that's just a suggestion.
Yes, yes.
Thank you.
Nirup.
Normally, as an examiner, but Nirup, I will not be happy if you add a stone here. Because this condition, as you very well said, there is no pain. Typically, the patient has no pain, no waxing. It is not a provisional diagnosis, not all the differential diagnosis in the theory. Confined to your case, and how best you will be able to explain. As Sarah said, it is good that you can mention that, but
Yes.
But normally it is not an acceptable one when you are talking about on one end on the periambulary carcinoma and other end on the stone. Your clinical examination postgraduate should be able to differentiate to some extent. You may be wrong or right, but you should be able to present in a way, not all putting your wishing in the diagnosis.
Yes.
How will you proceed? Go ahead.
Sir, one question, sir. Nirup?
Yes. Yes. Sir.
Though it is not applicable in this patient, what is Kurvaishier's law?
So in a case of obstructive jaundice, a palpable gallbladder is seldom due to gallstones.
Pardon?
In a case of obstructive jaundice, a palpable gallbladder is seldom due to, if a gallbladder is palpable, it is seldom due to gallstones.
Seldom due to gallstones. In that sense?
Not commonly or not usually associated, not because of gallstones. If the gallbladder is palpable, it is not because of gallstones.
What are all the exceptions of Kurvaishier's law?
So double impaction of stone, that is one stone in the end of CBD and one at the cystic duct CBD junction, oriental cholangitis, and Mersey syndrome. We might get palpable gallbladder with GB stones.
Any other things? Oriental cholangiohepatitis, mucosal of the gallbladder.
Mucosal of the gallbladder, empyema of the gallbladder. Yes.
Even carcinoma of the gallbladder.
Carcinoma of the neck of the gallbladder.
One more question. What is Klatskin tumor?
So the group of cholangiocarcinomas occurring at the Isla region is termed as Klatskin tumor.
Okay, go ahead.
So it is a case of obstructive jaundice. So first, I would like to see the LFT values. That is total bilirubin and the direct fractions of the bilirubin. And along with that, other parameters like enzymes, AST, ALT, and alkaline phosphatase level. And along with that, albumin. That would be my first investigation of the preliminary investigation. And since I'm suspecting it as an objective case, so I'm expecting an increase in the alkaline phosphatase and a direct fraction, increase in direct fraction of the bilirubin.
Okay, Nirup, you've done. Look, your diagnosis. How do you proceed? Is that first you have to the investigation is to confirm your diagnosis.
Yes, and then
Stage studies. So you first have to confirm whether there's jaundice.
Yes.
That is obstructive.
Yes.
And then the cause for obstruction.
Yes.
Right. So now how do you go about it?
Sir, first confirming the obstructive jaundice, as I said, sir.
That you've done, blood test you've done.
Yes, sir. After the LFT, then I would also get a PTNR also as well. And as a routine, I'll get viral markers.
Why do you want to get PTINR done?
Sir, I would like to see the synthetic function of the liver as well. So that would be, I would expect it to be deranged in the case of obstructive jaundice.
So why don't you get albumin and globulin done? Why PTINR?
So, PTINR, sir, so in obstructive jaundice, there is loss of absorption of the vitamin K, which is a fat-soluble vitamin. And this vitamin K is required for the
No, you said you wanted to look for liver function.
The synthetic function of the liver, yes, sir.
Right. So why PTNR then?
So because the prothrombin time, sir, is decided based on these factors, that is 2, 7, 9, and 10. It is also
no. Hang on.
Yes.
Nirup, the answer would be that PTINR are the earliest to be affected in liver diseases.
Okay, yes.
Right, and the first to be. Okay,
so sir, we have Professor UP Srinivasan, head of the Department of Surgical Gastroenterology, KMC, also joined here, sir. Sir, you are welcome to ask questions, sir.
Yeah, I already started asking.
Yes, sir.
Thank you.
Yes, sir.
Okay, so now you've got this patient, you've done the investigation, right? You've done an ultrasound. Sir. Have you got the ultrasound report with you?
Sorry, sir, I don't have an ultrasound.
Okay. Then what do you do? The patient's that you're in your OPD.
Yes, sir.
You've sent the investigation. Of what do you do for this patient? You admit him and do what?
Sir, I would like to admit the patient, yes. And after getting my blood report, based on that, I would ask a patient for an ultrasound abdomen, mainly to look for the hepatobiliary and the pancreatic region.
What will you look for in an ultrasound?
So since it is an obstructive jaundice, sir, I'll be looking first at the liver, mainly and the bile ducts. Is there any dilatation of the intrahepatic or the extrahepatic bile ducts, and is there any obstructive pathology?
Listen. Yes. Why don't you say it systematically? You start with the liver.
Okay, yes, sir.
In obstructive jaundice, what are the features you would like to see in the liver? Then come with the bile duct. Since the gallbladder is not there, you can't comment on that.
Yes,
then come for the lower end of CBD, pancreas, lymph nodes, free fluid.
Okay. Now that sir's told you.
Yes.
Now that you've got the patient is in the ward, what do you do now? You've got the investigations. What do you do?
So based on the USG finding, then I'd be deciding my further plan of management.
So you tell the patient, you wait, let the investigations come, I'll not do anything to you.
No, so definitely no, sir. No. Yes. Sir, I've admitted the patient. I would ask the patient to be on high carbohydrate diet. Ask her to take plenty of oral fluids. I would start also.
Oral fluids. She's vomiting.
No, sir. She is.
Why everybody says high carbohydrate diet? What is that? What do you tell the patient to
high
take?
Carbohydrate? Yeah.
Sir, it is said that the glycogen reserve.
No,
not at all. Not at all.
What do you tell the patient to eat? Or you have written high carbohydrate, the nurse asks you, what do you mean by this? What diet should I present it?
And is it important?
Yes, sir.
Is it important?
Yes. So I would ask her to eat the glucose-rich diet.
Only glucose? Rice. Only rice? What is the diet you actually prescribe? That it should not have, it should have very less fat.
Okay.
Yeah?
Yes.
Because you should not be able to tolerate that, digest the fat and produce steatorrhea.
Yes.
Should you discard the protein? Because already she's fasting, she's vomiting, a protein breakdown has already started.
Yes, I would also advise for the...
Look, Nirup, yes. Hang on. You have to go systematically on how do you manage this patient. So you have to hydrate the patient.
Yes.
You have to manage the nutrition. You have to prevent infection.
Yes.
Right? You have to manage coagulopathy, and you have to manage itching. Right? So then you say, how will you go about it?
Now you tell us in these lines. There are 5 things which you have to do, and what sir has said, you tell us the management in these these lines.
Sir, to improve her hydration, I would ask her to I'll encourage her to take oral fluids, and I'd also start her on IV fluids also as well. And I would also start on dextrose-rich fluid, and to improve her
Dextrose is not important. Look, Nirav.
Yes.
Don't.
So that would, yes.
Where have you read that you have to give dextrose-rich fluid? Where? Which book? Have they said only 5%?
No, sir, no.
Then why are you harping on glucose-rich, dextrose-rich? None of these are there. Sir also told you that you have to give food which is easily digestible. That's it.
Yes.
This thing of giving sugarcane juice and rice and sweet potatoes is out.
Yes.
Okay.
Yes.
So hydrate the patient. Why do you have to hydrate the patient?
So these patients are said to be in volume contracted state or the hypovolemic status, because there is obligatory loss of water with the bilirubin in urine.
No. Hang on. Obligatory loss of water with bilirubin.
The conjugated
Where have
bilirubin.
you come across this?
So you say the urine output will be high.
Decrease, sir. Maybe initially, but later on it gets.
Then where the fluid is going?
Why are these patients dehydrated? A jaundice patient, why is he dehydrated? Why are they dehydrated? Because they usually have nausea, they have decreased appetite, they can't take water enough. That is why. They're not losing it anywhere. There's no obligate loss of fluid due to bilirubin, please. So why do you have to hydrate the patient now? Tell me. Quick. We got to finish off in 10 minutes. There's something on hepatorenal syndrome. Okay. Then
yes, she is in hypovolemic state. She would go into hepatorenal.
Okay, forget it. Now, what about nutrition?
Sir, carbohydrate rich and protein rich diet. I would ask her to take dal, soya beans, or to increase her protein intake. I'd also advise her protein powder if she's affordable.
She's gonna digest. She's already having decreased appetite. Are you going to push all this kind of stuff into her stomach? She's gonna vomit it out. Have you heard of intravenous nutritional support?
Yes, sir. Yes.
So why are you pouring everything down her throat? You're giving her carbohydrates. You're giving her proteins.
Sir, yes. If
okay.
Sir,
what about infection?
I would prefer.
What about infection? Forget it. What about infection?
Sir, I would start her on antibiotics.
Why is
these
infection important here?
Yes, sir. So these patients are in a state of low to moderate grade of endotoxinemia. So
low to grade. What toxic?
Endotoxinemia. Sir.
Endotoxins. Where are endotoxins coming from?
Sir, there is an obstructed biliary system here, so there could be a
exactly. So that is prone to infection.
Yes, sir.
That's it. No endotoxins here, please.
Okay.
Right. You see the hepatorenal syndrome. Any other hepato syndrome you will get?
Yeah.
Is hepatopulmonary syndrome?
What is hepatopulmonary syndrome? Have you heard of it?
Yes, sir. There is a dilatation of the pulmonary vasculature that leads to a decreased oxygen saturation because of the hepatic dysfunction. Sir.
So the pulmonary hypertension or pulmonary pressure will be low.
The vasculature will be dilated, so the pressure will be low. Sir.
You can have another syndrome where the pulmonary hypertension can be also there. So there's a pulmonary. There's a two ways. Both pulmonary syndrome and pulmonary hypertension syndrome can also come.
Okay, what about coagulation now?
Sir, to correct the coagulation profile, sir, I would advise injection vitamin K, sir. for 10 mg for 3 to, yes, sir, IV intravenous.
Intravenous.
Yes, sir.
Okay.
You give
And-
intravenous?
Yes.
Yes, sir. Intravenous route, sir. Yes.
All
But
vitamin K can be given intravenous.
I'm sorry, sir.
Have you seen it being given intravenously?
What is the base on which they are preserved?
I don't know the base and what is preserved.
So it is a deep intravascular injection.
No, have you seen it being given intravenously? You're in third year. You must have given vitamin K.
Yes, sir. We have usually advise intravenously, so I've seen giving
Intravenously.
Yes, sir.
There is a special preparation. Intravenous is available, but it's a preparation. Normally with the
It's very rare. It's normally not available.
Normally it is better not to give. Meningioma preparation that will not be able to given intravenously.
Okay.
Suppose you have a normal PT in this patient, INR, normal INR in this patient.
Okay,
Will you
yes,
give
sir.
vitamin K or not?
Yes, sir. I would still give it.
Why? The INR is normal.
So maybe now it is normal, but it would be.
No,
it
the
would
answer
range.
is, listen to the answer. 50% of coagulation factor loss will reflect in the INR.
Okay. Yes,
Okay. For the INR to get deranged, there should be a loss of 50% of the circulating coagulative factors.
okay. Yes.
So all patients of obstructive jaundice, irrespective of whether PT INR is normal or not, should get that minimum dose of 3 to 5 days of vitamin K3 deep intramuscular. Okay.
What is the normal value? Is it normal for all everywhere? Same?
Value of INR, sir.
Yeah. It is same in your place and all the place. It is the same value always, or it depends on what?
Sorry, sir. I'm not aware.
So, what is the range you will when will you start treating your INRs? For this case, exceptionally, as Sir has very well explained, that we need to give even INR.
If it is normal, yes. Sir.
So, what special precaution take when you will take? Okay. More than 30% of the normal. Suppose there is albumin is low.
So albumin indicates that it is a chronic process, sir. I would just improve the nutrition status of the patient.
So exogenous albumin supply is not going to improve.
No, sir.
You have to give the liver metabolic function has to be improved.
Yes, sir.
Various means, whether that is it due to the stasis, somewhere you have to do the action and
yes.
Okay. So you have that any investigation which has clinching the diagnosis here?
So no, sir, I am not attached in this presentation.
What was the case? Have you worked out?
No, sir, it is yet to be evaluated.
Okay.
Yes.
I think we should call it also because we're running late. So should we go for the next case?
Can I, sir? You can take over.
Okay.
Should we allow the candidate to ask questions, sir, before moving to the next case?
Please.
Nirup, do you like to ask any doubts or any questions you want to clarify? Manoj sir, are you with us, sir? Manoj sir has joined. Nirup, yes or no?
I think so, sir is there, sir. Yes.
Manoj sir, your comment, sir?
Yes, sir. Yes, sir. I'm here, sir. I'm here. I'm listening everything.
No, sir. You want to ask anything or you want to share your comments? I'm asking, sir.
No, sir. He has missed a lot of things which we have taught him. I think he should go and revise what we have taught.
Yes.
No, Manoj sir, your candidate has done extremely well. And
yes,
he
I think
very composed, very confident of what he is saying, and very logically he is thinking. And there is a good sign, and we really appreciate your candidates.
And sir, best part that he has qualified for the MCH neurosurgery, sir.
Oh, great.
Very nice.
Very good, sir. Very good. UP sir, your comment, sir? Sir, mute, sir.
Yeah, I just wanted to tell him only one thing, a practical point. He was telling all about the blood investigations to diagnose surgical jaundice. Surgical jaundice is not decided based upon a blood investigation, because even for a primary sclerosing cholangitis, you may get a picture like what you get in an obstructive jaundice here, but it does not require surgery. The one investigation that you should tell to confirm that this is a surgical jaundice is ultrasound. Sir also told that in an ultrasound, if you get an intrahepatic biliary radical dilatation, then it is definitely a surgical jaundice. That one point I wanted to stress to you.
Yes, sir. Yes, sir. Other faculty, any comments? Om Prakash, sir, any comments from your side, sir?
No, it's okay. He has done very good. See, the temperament is very good. So, even in spite of all these questions, you kept the same cool head. That's good.
That is
the
very
problem
good.
is you want to do neurosurgery. That's why you are not interested in obstructive jaundice.
No, sir, no.
Okay. So, faculty, with your permission, we move to the next case. Nirup, you can stay with us for the discussion.
Yes, sir.
So,
Yes, sir.
this is the case of a soft tissue tumor, kindly contributed by Professor Sumati ma'am and Professor Vijay Kumar sir, head of the department at Government Salem Medical College, Salem. So, Daruni, you can introduce yourself, your unit chief, your head of the department, and start your presentation.
Yeah, sir. Good morning. Good evening, sir.
Yeah. Please share your video and share your PowerPoint. Sumati ma'am, are you with us? Do you have any challenge, Dr. Daruni?
Sir, I'm trying to connect my PDF and it's not connecting, sir. 1 second, sir.
No, if your friends are there, ask them to help you.
Okay, sir.
Niru, I will try sharing Daruni's presentation to you. Can you help to share in the Zoom? Niru?
Yes, sir. Yes, sir.
I've sent to you.
Okay,
You
yes, sir.
please share. I've sent to you in your WhatsApp. Have you received, ma? Niru?
Yes, sir. Sorry, I just got it now, sir.
Yeah, please try sharing it. Dr. Daruni, you please switch on your video alone. I requested Dr. Niru to share.
Yeah, sir. Yeah, sir. I on, sir.
You settle down. Your phone is keeping on moving. Settle down.
Okay, sir.
Yes. Nirup, you got it, Kana?
Yes, sir. Yes, sir. So just 2 minutes.
Yeah, take your time. Maybe I have to ask you to stay back and keep moving the slides as she grows. Sorry, Nirup, for pulling you up for this.
No, sir. I don't mind this.
You have downloaded, Kana?
Yes, sir.
Taruni, you can start your presentation. Nirupi, make it full screen, Kana. Thank you
Yes,
very
sir.
much.
Yes, sir.
Good evening, sir.
Taruni, yes, please start.
Can you hear me, sir?
Very well, ma. You please start your presentation.
Good evening, sir. This is Daruni. I'm from Government Mohan Kumaramangala Medical College. I'm a second-year postgraduate. Kumar, sir, and my sir, Dr. Sumati, ma'am. So next slide, please, sir. And I'm here to present a patient, 63-year-old male, a female patient, Mrs. Anjali, who came with chief complaints of swelling in the medial aspect of left thigh for the past 3 months and pain in the same left thigh for the past 1 month. History of presenting illness, patient was apparently normal before 6 months, after which, sir, actually, this is not the presentation which I sent, sir. This is not my final presentation, sir.
Okay. Let me try. Can you please unshare now? One second.
Yes, sir. Yes.
Nirupa, I've sent you the most updated one. Got it, Kana?
Yes, sir. I just got it now. Yes.
So probably I sent the earlier one, I think, the most updated one I've sent you. Faculty, please bear with us because she could not come on time for a trial. Students, please note, please avoid showing patients in full. Markers or blanket markers of the patient should be maintained. And also avoid telling the names of the patient in future so that this goes as a public record. So we have to give dignity to the patient's rights. So I request you in future, please avoid this.
Okay, sir.
Nirup, are you okay, ma?
Yes, sir.
Yeah. Is this the correct version, Dr. Daruni?
Yes, sir. Yes, sir. This is my final presentation. Sir. Thank you so much, sir.
So 1 second, they're just not moving.
So sorry for the inconvenience, sir.
I think you're okay, Kanai. Nirup?
Yes, sir.
Make it full screen, ma. Just press the screen share, screen show button.
So it's not going full screen.
Okay, ma, you just keep this side only and
yes,
keep
sir.
Advancing the slide. Are the slides moving in this
yes,
position?
Yes, sir. They're moving. Serious.
Yeah, please carry on with this. Ma. Yeah. Already getting delayed. You start your presentation, Dr. Taruni.
Okay, sir. History of presenting illness. Patient was apparently normal before 6 months, after which she started noticing a swelling in the medial aspect of left middle 1/3 of the thigh, for which she went to a local hospital where she was where she underwent excision for the swelling on 27/6/22. There was a delayed wound healing after 15 days. Then she started developing swelling above and below the excision site, which gradually increased to attain the present size. And this second swelling is present for past 3 months. And this pain is associated with pain. And the patient is also having a dull aching pain over the swelling, which is aggravated mainly on walking and relieved on taking rest and some kind of medications. And the patient is also having difficulty in walking because of pain. And patient is also having alteration in gait because of pain. And patient is also having loss of weight and loss of appetite. Other than that, bowel and bladder habits are normal. There is no history of trauma or fever. There is no history of ulceration or fungation over the swelling, or there is no history of any other swelling in the body. Past
Go ahead.
Past history, the patient is not having any comorbidities, and the patient is not having any history of exposure to sexually transmitted diseases. Personal history, patient is a mixed diet consumer, and she is not a smoker, not an alcoholic. Family history, there is no history suggestive of any malignancies or sexually transmitted diseases or hypertension or diabetes running in the family. Menstrual history, age of menarche is 17 years. She's having 3 live children. Last childbirth 20 years, and she had in menopause 10 years back, sir. On general examination, patient is moderately built and nourished. Patient
Daruni, just a minute. We would like to ask you a few questions on your history.
Okay, sir.
So what are the risk factors for What do you think you're dealing with, first of all, by history? What is this patient about?
Sir, I feel because it's coming back again after an excision, it could be a local recurrence of a tumor, or it could be some kind of benign mass that is actually spreading rapidly and converting into a malignant mass.
Okay, so you think it's a soft tissue sarcoma?
With just this clinical history, I can't delineate that it's a soft tissue sarcoma.
Okay,
but
your history is suggestive of it. So what
Yes,
are the
sir.
risk factors? What are the risk factors for sarcomas, soft tissue sarcomas?
So genetic mutations,
What kind of genetic?
it can be FAB syndromes or neurofibromas.
What syndrome?
FAB, familial adenomatous polyposis syndrome, Gardner syndrome, maybe. Sir.
Okay, what else? More common.
Neurofibromatosis.
Okay, that's other risk factors.
Other risk factors.
What is she working? Does she work?
No, sir, she's not working, sir. She's just a homemaker.
What does the family do? What does the husband do?
She's a widower, sir. She's not having husband, sir. He died of heart diseases like few years back, sir.
So what are the other risk factors for soft tissue sarcomas?
Some kind of radiation exposure might be.
Radiation. What else?
Then if it is an angiosarcoma, there can be arsenic exposure or that can be thoracoblast exposure.
Okay, so exposure to arsenic and vinyl chloride.
Yes, sir.
Right. So, okay. So what do these patients generally present as?
Sir, I can't get you the question, sir. General presentation.
What is the general presentation of a patient with soft tissue sarcoma?
Most commonly, it will be a swelling, sir.
Yeah, swelling where? Is it common in males or in females?
It's more common in males compared to females, sir, and extremity is more common compared to axial skeleton.
Right. So you've got 1 point here, but she's a lady. Okay. What else? Well, what else do they present as? What will the patient come and say? What has brought the patient to the hospital to you?
So pain also is the main complaint, sir.
So it is painful, right?
Yes, sir, it's painful, sir.
So what kind of pain? Just go back to your slide. Have you described the pain?
Yeah, so it's just a dull aching continuous type of pain, sir.
What else? Just go back to your slide, please. Dull aching pain, all of those swelling. Any aggravating or relieving factors?
Yeah, so it's aggravating on walking or doing work and relieved on taking rests, sir.
Any radiation?
She doesn't say any radiation, sir. It was just localized pain she was saying, sir.
So is it affecting her lifestyle?
Not much, but she's having difficulty in walking, sir. That's all. Like because of pain, she's actually having an antalgic gait. That's all, sir. Other than that, she can do all the normal activities.
Is she able to? Is there a complete range of motion of the joints there, of the lower limbs?
Sir. Yeah, sir. She's having complete normal motion of.
Is there any pain on moving the joints?
No, sir. She's not having any specific pain.
Like this is what exactly I want to tell you. I want to know more about this pain. Your history should come out whether the joints are involved or not.
Yes, sir. Okay, sir.
Isn't it? Which
Yes,
is not
sir.
coming out in your history.
Okay, sir.
History of ulceration or fungation. What did you ask her about? How did you ask her?
Sir, any like discharge or some kind of superficial ulceration or fungation.
Whether she required any dressing for any wound there. Was there any wound there or not? Isn't it? That's how you ask.
Yes, sir.
I'm asking you. That's how you ask, no?
Yes, sir. Yes, sir.
You can't. She won't understand ulceration function. You have to ask her whether there was a wound there, whether she required dressing or not.
Yes, sir.
Okay. The first, you said it was excised before, was it? Just go back to the next slide, please. Go to the next slide. This swelling has been excised before.
Yeah, sir. Before 6 months, she was having a like small swelling.
Where is that history? Where is that history?
Sir, I gave it in first page, sir.
Nostril swelling, she underwent excision.
Yes, sir.
So what happened after the excision? The wound healed completely.
Sir, yeah, sir, wound healed with a scar at the center, sir. After that, she was apparently, after that excision, she was normal for 2 months, sir. After that, she noticed a swelling above the scar site. And then she noticed another swelling below the scar site also, sir. And that started growing in size
But the
rapidly.
scar never gave way.
No, sir, scar never gave way, sir.
Right. Because usually if there's a residual tumor, I won't expect the incision site to heal completely.
Okay, sir.
Right. Malignancy is one of the commonest causes where the wound doesn't heal.
Okay, sir.
Okay. So anyone else? Okay.
No,
Let's
you
go
ahead.
Right. Let's go to the examination, please.
It's a general examination. Patient was moderately built and nourished. Patient was conscious oriented. Patient was afebrile. Pallor was present. Hydration was good. Patient is not having any icterus, cyanosis, clubbing, or pedal edema. And patient is having multiple left-sided inguinal lymph nodes. And on vitals are stable, like blood pressure, pulse rate, and saturation was normal. On systemic examination, cardiovascular system, both heart, first and second heart sounds were felt, and respiratory system, normal vesicular presence was present, no added sounds. Parabdominal examination was
Dr.
soft.
Dr. Dharwani.
Yes, sir.
Systemic examination is not very important here.
Okay,
Regional
sir.
examination is. So let's go to the regional examination first before we start off with the systemic examination.
Okay, sir. Local examination, after getting consent from the patient, after adequate exposure, I examine the patient first in lying down position, then on standing position, sir. On lying down position, like left thigh appears larger when compared to right thigh, and I can see a lobulated swelling of size 13 cross 14 centimeter in the medial aspect of left thigh with the healed scar at the center that is present on the middle one third of the thigh, and it is actually having a very diffuse margin, and the skin over the swelling was appearing normal, and there is no dilated veins over the swelling. There was no visible pulsation over the swelling. There was no ulceration or fungation, and there was mild discoloration noted, and this was after taking a true cut biopsy. And on palpation, the swelling was not warmed. There was mild tenderness that was present. The surface appeared smooth and margins were diffused. Swelling of size 13 cross 14 centimeter was present on the medial aspect of left thigh. There was no abnormal pulsation that was felt. On palpation, it was firm to hard in consistency. Skin over the swelling was free, and there was no satellite nodules that was palpable. Slip sign was negative. Swelling was also not fluctuant. And on contraction of vastus medialis muscle, the swelling became more prominent. The mobility of the swelling was restricted on contraction of vastus medialis muscle. There was no abnormal pulsation that was felt. There was no bruit. Femoral pulsations was normal. Knee joint movement was normal, and hip joint movement was normal in all planes. Examination of inguinal lymph node. In the left side inguinal region, there were multiple vertical as well as horizontal group of lymph nodes that was palpable, that was separate, and each of size 1 cross 2 centimeter. Then no other lymph nodes was palpable, and right leg was appearing normal on inspection as well as on palpation. And on the right side, there was no lymph node that was being palpable. And provisionally, I feel it is a soft tissue malignancy that is present on the left middle aspect of thigh with multiple left inguinal lymph nodes, sir.
Aroni.
Yeah, sir.
It is very important
Yes,
that
sir.
in your history and your examination, you
Yes,
find out whether the neurovascular and the muscle power, the sensation, all
Yes,
that
sir.
has to be elicited completely,
Okay, sir.
including involvement of the blood vessels, right?
Yes, sir. Yes, sir.
So that has not come out very clear. You have not examined the patient's gait.
Peripheral vascular disease.
We have not examined the neurovascular system. We have not examined the joints.
Yes, sir.
right?
Yes, sir.
You have palpated the femoral pulse, right?
Yes, sir.
Yeah, but what is more important here? Proximal pulse or distal pulse?
And distal pulse is more important, sir.
Yeah, so why haven't you not done that?
Popliteal pulsation was felt, sir. I
Mhm.
just didn't mention in the presentation.
And distal, further distal?
Yeah, sir. Distal pulsations were felt, sir. Like popliteal was felt, anterior tibial, posterior tibial, and dorsalis pedis, everything was felt, sir.
Okay. What do you understand by the neurovascular examination? What all you need to see?
So any kind of tingling sensation that is present.
Tingling sensation? That is the patient
Yes.
complains of.
Yes, sir.
What do you want to see?
Sorry, sir. I don't know clearly, sir.
You have to see sensory, motor. Isn't
And
it?
sensation. Okay.
Yeah, sensory and motor sensation. I mean, sensory, touch, pain, temperature, and motor. In the motor, there are this
Extension
power.
and flexion.
They are all
Tone
movements.
and reflexes.
Yeah.
Okay.
You are making a diagnosis of sarcoma based on what? On the nodes which you are palpating?
And also with the history where it is rapidly growing in just 2 months, sir.
Is that rapidly growing means? Sarcoma, you think that within 2 months it grows?
No, sir. I feel like it's a local recurrence after excision. That's why, sir.
No, recurrence is different. The growth is there. You said there is a scar, but
Yes, sir.
when you are saying the inspection, you said it's a lobulated mass. On palpation, you said it is a smooth surface. It's a regular surface. There is no lobulation or nothing you mentioned. And one side you are saying there is a scar, but the next side you are saying that is a skin over the swelling is completely normal. And you are more giving importance to nodes, and based on that, you are now coming to a conclusion of the sarcoma without examining neurovascular, without examining other systems. And what made you to think it is a? And you are looking for a slip sign also.
Yes, sir.
How did you check for slip sign? And where did you feel for the slip sign?
I have to over the margin of the swelling. I was keeping my index finger.
And you said margin is diffuse.
Yes, sir.
So, and you said mid thigh. Then you are saying the swelling is the size of the swelling is large, extended down also.
Yes, sir.
You go. What is? Don't put in another findings unnecessarily. Say what is your palpation? What is your inspection finding? As for the any swelling which you are saying, number of swelling, and you look for the satellite nodule and transit nodule. So,
yes.
what is the difference between satellite nodule and transit nodule?
Sir, I can't hear you say satellite nodule and.
Oh.
Hello, sir.
You said there is. You look for satellite nodule and transit nodule.
Yes, sir.
What is that? What do you mean by satellite nodule? What is not the transit?
Sorry, sir. I don't know clearly, sir.
Within 2 centimeter, if you are getting that is okay. Within 2 centimeter of the mass, we are getting that it called as a satellite nodule. On the way to the nodal region, and anyway between that, you are getting a nodule that you are going to make it a transit nodule. So in a sarcoma, we don't expect a transit nodule. We don't expect that, which is common in which condition?
Breast diseases, sir.
Melanoma.
Yes,
if
sir.
you are thinking of melanoma, more of things of a melanoma.
Okay, sir.
Okay, go ahead.
Then investigations. Routine investigations, then echocardiography, ECG, then true cut biopsy, FNAC from the inguinal lymph node, then ultrasound scan of the soft tissue mass, then MRI left thigh, USG abdomen, X-ray chest and CT chest. These are the investigations we did.
Very nice. What
Baseline
is routine for your institution may not. So what you get to present, what is the specific investigation you are going to do? More than going to tell what you are going to get by doing a blood hemoglobin here.
Anemia.
No, Dharani, hang on.
So that
is there an importance of the previous scar?
Yes, sir.
What is the, that's what is look, your first investigation is to confirm your diagnosis.
Yes, sir.
So now how do you go about confirming your diagnosis? What is the importance of that scar there?
Sir, incomplete excision might predispose to local recurrence, sir.
Look, the scar has to be, because if it's a, okay, let's go about that the other way. What is the investigation to confirm your diagnosis?
Sir, like to confirm the diagnosis, I will prefer true cut biopsy, sir.
You'll get a core biopsy. Okay. Why do you want a core biopsy? Why can't you get an FNAC?
Sir, in FNAC, you can't delineate, like you will get only few type of cells and you can't delineate if it is a malignancy or not.
So FNAC cannot tell you whether it is malignancy or not.
Yes, sir. Like we can't completely lay on FNAC in this case, sir.
In soft tissue sarcoma,
yes, sir.
Why is it important that you should have a core biopsy? You are right, core biopsy has to be done. But why is it in soft tissue sarcoma? Why do you need to have a core biopsy? It's mandatory. You should go ahead with only the core biopsy, especially when you have strong suspicion for that.
Okay, sir.
No, why? Give us the reason.
What are all things you need to know, which is important as far as the management of this patient is concerned, which can be seen in the core biopsy?
Sir, mitotic index, sir.
Before that,
nuclear morphology.
Soft tissue sarcoma staging has got something which FNAC cannot give.
Yes.
Can it show the grade?
Size of the tumor, sir. Size of the tumor can't be the.
No, grading.
Yes, sir.
What is the grading system? You have high grade and low grade of tumors?
Yes, sir. We have three grades, sir.
So can you get that by FNAC, or do you need a true core biopsy for it?
Core biopsy, sir. Because we need like a mitotic index for staging, sir.
Okay.
Yeah, you're right. That's one of the other reasons is mitotic index you'll get.
Right.
Yes.
Okay. So you can do a core. Do you have the biopsy of the previous surgery?
No, sir. Information is not available, sir. Patient didn't collect the report, sir.
Where was it done?
It was done in like Kalakulchi GH, I think, sir.
So they couldn't get a biopsy report from there?
Yes, sir.
Okay. Okay. So now you've done a core biopsy. Anything else you would like to do before?
Then MRI, sir, to know the compartment that is getting involved, sir.
Okay, you want to know the MRI. What else will you know for MRI? From MRI. One is the compartment. What else?
Then the structure that is getting arising, sir, like whether it is from nerve or from blood vessel or from muscle, because
That
MRI is actually.
your core biopsy is going to tell you.
Yes, sir.
Why do you need an MRI for that? Look, what treatment would she be undergoing for a recurrent? What do you think she would land up with?
Amputation, sir, if it is like very high.
Okay, we would like to go in for an excision, right? For
Yes,
a
sir.
complete
Yes, sir.
excision. So,
Yes, sir.
what are the structures which this tumor could be involving?
It could be nerve or blood vessel.
Right. It could be the bone, it could be nerve, or it could be the blood vessel and the muscles.
Yes, sir.
Right. So
Yes, sir.
we want to know the vascularity or the relationship to the vessel.
Yes, sir.
A partial relations to the partial planes.
Yes, sir.
Right. So
Yes,
all
sir.
this will be got by MRI. But what about bone?
For bone, we can do X-ray or CT, sir.
X-ray is not important. You get a CT done.
Okay,
right?
sir. Okay,
For,
sir.
for bone, we get a CT done.
CT. Okay, sir.
Any other investigation?
CT chest, sir. Because lung is being the most common site of metastasis in soft tissue sarcoma. To know the lung metastasis, we can go for CT chest, sir.
Okay. What else?
Then I can go for ultrasound abdomen to see liver mets, sir, because liver is being the second most common site of metastasis.
Okay. What about an angio?
Angio, if it is an, I'm not sure about it, sir.
No,
Of
if
course
you
you
are
like to
doing
get
an
an angio.
MRI, if you're doing an MRI, you can also have an MR angio in the same setting, isn't it?
Same setting.
Yes, sir.
Yeah, it is very important. See, the approach to soft tissue sarcoma in the present day is limb saving, right? So at every possibility, you'll always exclude out whether the vascularity is compromised or not, if there are runoffs present or not, how the limb can be, if it all has involved, or in case the vessel, how it can be, the limb can be survived.
Yes,
Okay.
limb salvaging surgeries. Okay.
So what you can do is you can also have the same the MRI of the limb as well as the MR angio.
Okay, sir. Hello, sir.
Yes. Yeah. Okay. So now, okay, let's ask you a basic question. What is the difference between a sarcoma and a carcinoma?
Sarcoma, it's arising from mesenchymal tissues, while carcinoma.
Carcinoma is very basic.
Sir, carcinoma, it's from like
from epithelial tissue. Epithelial tissue.
Sir, sarcoma is from mesenchymal tissues, while carcinoma is from epithelial tissues, sir.
Right. Next. What are the other differences?
Carcinoma usually have like lymphatic spread, while sarcoma has a blood spread, sir.
Okay. So it is vascular spread more common?
Yes, sir.
And lymphatic is commoner in carcinoma. What else?
And age of presentation, like sarcomas are more common in like younger people, and carcinomas in advanced ages.
Right. What else? Sarcomas are more vascular.
Yes, sir.
And
carcinomas
poorer prognosis, right?
Okay, sir.
Right. Okay. See you.
Nirup, can you move the slides, Kana? Nirup? Next slide.
Yes, sir. Yes, sir.
Dharani.
Yes, sir.
Is there any role for FNAC in case of sarcomas?
So we can do FNACs on the lymph nodes, sir, so to see if it is like metastasis from sarcomas or not.
Any other indication for FNAC?
Sir, in case of recurrences, can we do FNAC, sir?
In case of recurrences, we can go for FNAC.
FNAC.
Okay.
Okay. Then we did ultrasound of left thigh, in which there was a well-defined hypoechoic solid mass lesion in the medial aspect of left thigh that is present in the intermuscular plane with good vascularity. And there was like 3 swellings which was distinctly present, like 6 cross 14 cross 6 centimeter in the middle aspect of distal thigh, and in the middle thigh it was 4 cross 4 centimeter, and in the proximal thigh it was like 1 cross 4 centimeter.
Next slide.
Next slide, sir. MRI of left thigh was also done, in which there was hypointensity lesion with diffusion restricted lesion in the intermuscular plane that was present deep to gracilis muscle and sartorius muscle, and of size 6 cross 4.5 cross 6 centimeter in the upper 1/3 and 13 cross 6 cross 5 centimeter in the middle 1/3. And they gave us provisionally as feature suggestive of plexiform neurofibroma or soft tissue tumor. And this is like metastatic workup, like X-ray test was normal, CT test was normal, and USG abdomen was also normal. Management for soft tissue sarcoma is nowadays like multidisciplinary approach with opinion from radiation oncologist and surgical oncologist. And previously, like medial compartment excision was done. Nowadays, we are trying to do limb salvage surgeries, and we are sandwiching it with either chemotherapy or radiotherapy.
Dharani?
Yes, sir.
What are the types of sarcomas that may spread to lymph nodes?
Sir, rhabdomyosarcoma, sir.
There are so many sarcomas.
Yes, sir.
Clear cell sarcoma, epithelioid sarcoma, alveolar software sarcoma, synovial sarcoma, high-grade
Yes,
rhabdomyosarcomas.
Yes, sir.
What is the significance of lymph node in sarcomas? So most of the tumors will be having like hematogenous dissemination, except like Ewing sarcoma, rhabdomyosarcoma, which will be having lymphatic spread commonly, sir. The significance here is whenever there is a node, the stage becomes 4. 4A.
Yes, yes,
so whenever there is a distant metastasis, it becomes 4B.
4B. Okay.
Yeah. What are all the limb salvaging procedures we can apply? So previously, we either go for compartmental excision or go for amputations.
Amputation, yes, sir.
Yes. Nowadays,
now we can go for the intralesional excision or marginal excisions or wide local excisions, sir.
So
in which marginal excision, we have to always sandwich it either with radiotherapy or chemotherapy to prevent the local recurrences.
What is the role of chemotherapy in soft tissue sarcoma?
Chemotherapy, we can either give neoadjuvant or as an adjuvant therapy, sir. Neoadjuvant therapy will actually downstage the disease, after which we can go for excision biopsy so that we can have a clear negative margin, sir.
So chemotherapy has got a limited role as far as the adults are concerned.
Yes, sir.
Whereas it has got a very significant role in case of pediatrics. In case of a soft tissue sarcoma in a pediatric patient, chemotherapy has got a very strong role. Particularly drugs like doxorubicin and ifosfamide has got a very significant role. Whereas in adults, the chemotherapy has got a very limited role. Whereas the radiotherapy has got a very significant role in adults.
Okay, sir.
Yes. So, for example, it is a hypothetical question. If the lesion, soft tissue sarcoma, from one compartment is
Okay, sir.
abetting with the other compartment. What is your line of management?
Then
Previously, when it is involving more than one compartment, we have to go for
go for
amputation.
the amputations. Yes, sir.
What is the current scenario?
Sir,
So we can go for neoadjuvant.
wide local excisions with radiotherapy, sir.
We can go for a neoadjuvant radiotherapy.
Okay, sir.
At times we can add chemotherapy also, and
Okay,
try to
sir.
downstage the tumor and make it confined to a particular compartment and do a compartmental excision. And even you can go for vascular grafts in order to save the limb.
Okay, sir.
Is there any role for isolated limb perfusion in sarcomas, where isolated limb perfusion is used as a treatment previously or still currently in use?
Sir, sorry, sir. I'm not aware of it, sir.
Isolated limb perfusion. Have you heard of malignant melanoma?
Yes, sir.
In malignant melanoma, if it is confined to a limb,
Yes,
if it is
sir.
confined to a limb and there is a satellite or in-transit lesions,
Okay, sir.
and the disease has not gone to distant sites, we can use this isolated limb perfusion.
Okay, sir.
The drug commonly used is melphalan, and we have to go for hypothermia. The temperature must be 40 degrees Celsius. That is what we call it as isolated limb perfusion. That is an ideal treatment for malignant melanoma, which can also be used in soft sarcoma.
Okay, sir. Where it is like low grade and confined to some.
Yeah, for saving the, salvaging, one among the salvaging methods for
Okay, sir.
soft tissue sarcoma.
Okay, sir.
Okay, Dharani, what are the
Yes, sir.
indications for amputation in soft tissue sarcoma?
Sir, if it is rapidly growing tumor,
No,
and
not rapidly growing. Not rapidly growing.
at the time of presentation, if it is associated with metastasis, sir,
Then you won't go for amputation.
then it will be palliative therapy.
Think about it. When you have to go for amputation?
When neurovascular bundles are also getting affected,
Right.
sir.
So when there's a major neurovascular encasement, what else?
If it is like more than one compartment is getting affected.
Right. Multiple compartments too. Very good. What else?
If the size of the tumor is so large or something, sir.
No, that's the size is not very important. Where multiple bones and joints are involved.
Okay, sir.
Right.
Yes, sir.
When the whole disease, the
Yes,
limb
sir.
is completely involved.
Okay, sir.
And there's recurrence with multicentricity.
Okay, sir.
What is the role of radiotherapy?
So we can either give preoperative or we can also give post-operative radiotherapy.
So what kind of radiotherapy is usually preferred here?
So brachytherapy is preferred more than external beam radiotherapy, sir.
Okay. And what do you mean by palliative external radiotherapy? When is it? What do you mean by that?
When
Have you heard of it? Yeah, go on.
So when you have like more metastasis, we can't go for like amputations or excisions. Then we can go for radiotherapy, sir.
So when the tumor is fully fungated and bleeding and you can't do anything much about it, then you have to give a palliative radiotherapy.
Palliative radiotherapy. Okay, sir.
Your tumor was a neurofibromatosis plexiform, was it? What was it? What was the diagnosis of your tumor?
Sir?
What was the diagnosis? histological diagnosis?
So they in Ewing sarcoma or plexiform neurofibroma was a true cut biopsy report, sir.
Okay. So what is the difference between NF1 and NF2? Any idea?
Sir, in neurofibromatosis 1, you will be having like schwannomas.
Okay, what else?
So that chromosome is also different for neurofibromatosis 1 and 2.
No, it's different, but you have to tell me.
So
Okay, 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 it's okay.
So like neurofibroma 1, it's like chromosome 17 and 2, it is chromosome 22, I think, sir.
Okay.
And neurofibromatosis 1, like it's more common in
It is autosomal
childhood.
dominant 22. Right. Okay, that's fine.
Okay, sir. Then neurofibromatosis 2, you will be having like schwannomas, meningiomas.
So basically intracranial stuff.
That's more common in neurofibromatosis 2 when compared to 1, sir. And in 1, you will be having more amount of skin lesions like caphiolar spots and plexiform neurofibromas like that, sir.
So in your examination, did you look for caphiolar spots?
There was no caphiolar spots, sir.
But you didn't mention it.
Yeah, I didn't mention it, sir.
Okay. Anything else? So, I mean, there's a lot to ask, but.
Sir, Som Prakash, sir, anything else to add, sir?
It's okay. Eh? This will be a short case, I hope.
Yes, sir.
Yeah,
Usually it is a short case, sir. Yes,
short
sir.
case. So.
I think she has answered many questions, in fact. The staging you must read very well.
Okay,
right?
sir.
Yes.
Okay, sir.
And the ISCs, the various ISCs which are used. So you
Okay,
need to
sir.
have basic understanding of the immunohistochemistry to find
Yes,
out the
sir.
cell. Because nowadays, previously, the neurofibroma was given various, so not neurofibroma, soft tissue sarcomas were given various names. But after the immunohistochemistry, the names
Yes,
have
sir.
been changed to more lineages, right? Depending
Yeah,
on
sir.
various, yeah. So that is what,
Vimentin.
yes. So these various lineages of tumor, and accordingly the treatment and and as you have rightly said, the
Yes, sir.
mitosis. Yes, mitosis. Staging is drastic changes have taken place in soft tissue sarcoma, especially even now if the bone is also involved. So they are also supporting to preserve the limb as well as use various radiation techniques.
Yes, sir.
Yeah. So yeah, that's okay. For a short case, you have done good.
Thank you, sir.
Thank you, sir. I also could see Professor Anita there, ma'am, and Manoj sir and Anita ma'am. Do you have any comments, sir, madam?
I think she has done well. And
Yes, sir. Any area where she should read more or anything, sir, from your point of view?
I think she should read about the different types of radiotherapy, brachytherapy, doses.
Okay, sir.
Yeah.
Okay, sir.
Good evening. She has done very well.
Yes, madam.
Thank you, ma'am.
She needs to fresh up things. That's it. She has done very well.
Thank you, ma'am.
Thank you, ma'am. Thank you. And
Thank
Karnakaran
you.
sir, Rajiv Sakai sir, before closing, anything you'd like to add?
No, sir. Thank you.
Sumati ma'am?
I think.
Sir, Sakai sir, tell me, sir. You had started.
No, I think she's done well. It's a short case, but a bit more of in short cases, examination of the case is more important than discussion.
Okay,
and you
sir.
must do a complete examination, especially in STCs where
Yes,
involvement
sir.
of the bone, the muscles, the neurovascular bundle, everything has to be thoroughly examined, right?
Okay, sir. Okay, sir.
Madam, would like to give your comments, ma'am? Sumati ma'am? Ma'am, you are in mute mode, ma'am. Ma'am, you are muted. Any inputs you want to give, ma'am? Thank you for giving the PG for this week.
This is the first time she's presenting.
No, ma'am, I think she did well. I'm sure all the examiners are very happy. all our senior examiners across the country. So if they are happy, then your candidate is good. It shows the amount of training goes in the department. Thank you very much. With the permission of the faculty, can we call the session a close, sir?
Yes, sir.
Yes. Good night, everyone. Thank you so
Good
much.
night, sir. Good night, sir.
Thank you.
Suprakash sir, Anita ma'am, Karnakaran sir, Sakai sir. Thank you for joining. We look forward for next week. Sir, Somprakash sir, can I ask one of your PGs to present next week, sir?
Okay, I'll let you.
Any exam cases you give allot to them, sir, and ask them to share the PPT, sir. Thank you very much, sir.
Thank you.
Thank you, sir. Thank you. Thank you.
Thank you, sir. Good night, sir.
Thank you, Nirup, and thank you, Daruni.
Thank
You
you,
are both
sir.
of you did good job. Good luck to you also.
Thank you.
Thank you, sir.
Thank you.
Thank you, sir.